So we've arrived on scene to a 40-year-old male who has fallen 6 meters off his roof onto the concrete ground. We've arrived, the scene is safe. On our initial assessment, the patient is unresponsive to pain and he is posturing as well. All right. Akash, can you please give me a full set of vitals?
Copy.
On ABC, his airway is clear and patent, his breathing is irregular, and his circulation, he's warm with a heart rate of 50. So I'm now going to perform a secondary assessment, and upon performing my secondary assessment, I have found that he has a boggy patch on the back of his head, roughly 6 centimeters in diameter. His GCS at this stage is 5, made up of eyes 1, verbal 2, and also motor score 2. So I'm calling him a status 1 at this stage. Alright, Akash, what are those vitals?
Brody, we have a heart rate of 50, a blood pressure of 160 over 90, he has a rest rate of 12 and it's irregular, he has a BGL of 7.6 and a temperature of 37 degrees Celsius.
Okay, fantastic. So at this stage I'm considering a TBI, and Akash, if you could please also call for backup, and then R50 who is RSI capable.
Copy.
Come back when you've done that, please.
Yep.
Okay, great. So while Akash is doing that, I'm going to treat for my TBI. So airway is patent at the moment. I am going to place a towel under his head to get optimal airway position. And I'm also going to place an OPA just to maintain that airway. Measure the OPA. Now with breathing, I'm going to place a non-rebreather at 10 litres per minute to treat for TBI. And also I'm going to set up a BVM because he has irregular breathing. In case it deteriorates, it's going to be to the side in case I need to use that with PEEP set at 5 centimeters of water. I'm going to place that here. For circulation, I have placed an IV in. We haven't collared him due to his agitation. So with the agitation, I'm also going to give him 2 milligrams of morphine. I don't want to give him any more due to his breathing in case it decreases his respiratory drive. So we'll give him 2 milligrams of morphine. This has been drug checked by my partner. And I'm also going to set up some fluids, but we're not going to run those just yet. I am considering this patient does have Cushing's reflex or Cushing's triad because he does have irregular breathing, he is hypertensive, and he is bradycardic. All right.
Brody, our R50 with RSI capability is en route, ETA 10 minutes, and he's asked if you could please prep for an RSI with an RSI checklist.
Okay, fantastic. So what we're going to do now is we're going to extricate this patient into the back of the ambulance and start preparing for RSI. So we have now extricated the patient to the back of our ambulance, and I have my offsider holding the patient's head currently. We're still treating for TBI at this stage, so I'm trying to prevent hypoxia, hypo and hyperventilation, as well as hypotension. All right, so I do now have bilateral IV lines in, and I'm going to set up some fluids to just keep those lines open. We don't want to run it too much currently because we're still sitting at a blood pressure of 160 systolic. So the first thing I want to do now while preparing for RSI is I'm going to place an ETT tube holder underneath the patient's head. So Akash, forget you to lift the head, please.
Copy.
So we're going to place that underneath, ready for when our R50 comes, and we're now going to secure the head. So I'll place these towels inside the patient's head, and we'll tape them down as well. Okay, so my patient is secure now. Akash, if I could get you to start driving towards our R50.
Copy.
And I can do the rest. So what I'm going to do now is prepare for RSI using the St. John RSI checklist. So first thing we need to do is we're going to place some nasal prongs, but we're not going to turn the oxygen on at this stage. Nasal prongs are on, and we're going to go through the checklist now. Right, so we're also going to get our BVM ready. We're going to set that aside. It does have a PEEP on it at 5 centimeters in case we do need to ventilate this patient. We have our monitoring on, we have our ECG on, we have our blood pressure cuff, and we have our SpO2. We're also going to set up our end-tidal CO2 and just place that next ready for the ETT. So that's all ready to go. Monitor is on. We're going to leave some space to the right of the patient's head for the RSI gear. We have IV access and we have our fluids running. I have drug checked these with my partner. We have that airway position in an optimal place. I have rechecked the airway. That OPA is still securing the airway. We have our suction here. Turn it on, make sure it's working. So we're going to leave that off, ready. We have our ventilation bag. I'd also, before RSI, get a full set of vitals done in preparation for when we do RSI, and I'd update the RSI officer on the way of my patient's status, ready for when he does arrive. I'll clean away any unnecessary gear that we don't need, so that we do have optimal room. If the intensive care paramedic cannot visualise the cords within 15 seconds or cannot intubate within 30 seconds of laryngoscopy, then the intubation is said to have failed. In this case, manual ventilation should be performed with a BVM and an OPA or NPA. However, hyperventilation should be avoided, as this may cause secondary brain injury, causing the patient's condition to deteriorate further. Endotracheal intubation is allowed to be attempted once more with a bougie and with or without a different blade. The offsider can help the ICP by maintaining the optimal airway position of the patient and by providing anterior tracheal pressure. If end-tidal CO2 is above 5 mm of mercury after ventilation, then the crew should consider post-intubation management. If end-tidal CO2 is below 5 mm of mercury, then the tracheal tube should be taken out and an OPA or NPA inserted. If you're able to ventilate the patient at this stage, then you can continue with basic airway care. If the patient is unable to be ventilated, then a cricothyrotomy should be considered.